Okay, when we talk about the neuromuscular blocking agents, you've got several of them listed there. The one that I'll point out is succinylcholine. Remember, succinylcholine is the only neuromuscular blocking agent we have that's depolarizing. It's the only one that works by stimulating the end receptor, and because of that we get fasciculation, or that shaking type of appearance. And when we talk about all the bad things associated with succinylcholine in a minute, it all kind of basically goes back to that whole fasciculation. But there are some advantages to Sux, and that's why some people still continue to use it. The biggest advantage is the induction time. It comes on very quickly, within usually less than a minute. And then the other thing is the duration. It goes away very quickly. Okay, when we talk about rocuronium is another one that I want to point out because it's really made a big move into emergency medicine, because it's really kind of an ideal agent. Remember, rocuronium, vecuronium, atracurium, pancuronium, all those other oniums, those are all non-depolarizing paralytics. Remember, the way they work is they prevent the motor receptor end plate from actually being stimulated by the succinylcholine. Think of them as kind of being like the Great Wall of China. They prevent those acetylcholine molecules from actually touching the end motor plate and stimulating it. When we talk about rocuronium, the reason why rocuronium is so great specifically is because it's the only one of these drugs that has an induction time that's as fast as Sux. Remember, we said the whole idea behind RSI is we want the patient to sleep and paralyzed at the exact same time. Well, we can do that with rocuronium. When we talk about rocuronium, we're talking about a dose usually somewhere between, the textbooks say 0.5 and 1, but most people actually use just 1 milligram per kilo. At 1 milligram per kilo, that's usually going to buy you about 20 to 30 minutes of paralysis. And when we talk about the other advantage to rocuronium, it's very hemodynamically stable, almost never makes people tachycardic or hypotensive. Okay, when we talk about vecuronium, atracurium, and pancuronium, remember they all work the exact same way as rocuronium. The only difference is the induction time and the duration time. And some of your other drugs, specifically atracurium and pancuronium, they may have some histamine release to them, so it's not uncommon for those drugs to actually cause a little bit of tachycardia, or maybe even a little bit of hypotension. Okay, when we talk about succinylcholine, going back to that for just a minute, remember we said that it was a depolarizing paralytic. When we talk about the way that it works, we said that all succinylcholine was a ton of acetylcholine just flooding the receptor site. If you look at the drug insert for succinylcholine, you basically see it's an acetylcholine attached to an acetylcholine. And the only real indication for succinylcholine is paralysis to facilitate intubation. When you look at the literature, there are some places that have used succinylcholine as a drip in order to maintain paralysis, but by and far that's pretty rare. Most places only use it to actually get that initial paralysis and to get the patient intubated. Now, when we talk about the contraindications to succinylcholine, there's several big contraindications, and if you can remember 3 things, you'll cover them all. The first thing is, remember the eyes. Remember that succinylcholine, we don't want to give it to anybody with eye problems. And the specific eye problems would be like penetrating eye injuries, narrow angle glaucoma, increased ocular pressure, anybody like that. We don't want to give those patients Sux. The second set of patients that you want to remember is anybody with a history or a family history of malignant hyperthermia. If they have a history or a family history of malignant hyperthermia, that's a contraindication to succinylcholine. And the third big subgroup of patients that don't need succinylcholine, or that should not get succinylcholine, are anybody who has, or you suspect has, hyperkalemia. So who would have hyperkalemia? Well, that would be like people in renal failure, people with a demonstrated high K on their labs, patients who've had massive muscle damage, patients who have burns that are greater than 24 hours old, patients who are in rhabdo, any of those types of patients. Any of those people you don't want to give succinylcholine to because of the increase in potassium that comes with the fasciculation. Okay, once we've actually given our sedative and our induction agent, our induction agent and our paralytic, then the next thing we want to do is we want to get the patient in the appropriate position, and we want to protect them. And so this brings us to our next P, protection and positioning. Remember, appropriate positioning for intubation is the sniffing position. The sniffing position is not this, or excuse me, it's not this. Nobody ever sniffs like this. People don't walk around sniffing things like this. Remember, the sniffing position is head forward, neck out. So this is the appropriate sniffing position. And one of the ways that we can tell if we've got a patient in the appropriate sniffing position is the holes in their ears should actually form along the same plane as the front of their chest. If we can get them in that position, that dramatically increases the chances that we're going to be able to successfully perform a laryngoscopy and get the tube in place. In fact, if you're one of those people that every time you look in the airway you see like a Cormack and Lehane 3 or 4, I would suggest to you that probably your issue is head positioning. If we can get the head in that true sniffing position, dramatically increases the chances of intubation, because as you recall from the graphic there, it helps to line up our 3 axes. Now, the other thing that we want to do at the same time that we're getting ahead in the appropriate position is we want to protect the patient. How do we protect them? By pushing down and holding down on their cricoid ring. Remember that by doing Selleck's maneuver, the whole reason for that is to decrease the potential for the patient to passively regurgitate, and that should not be something that's asked for, and that's not something that should be released. And what I mean by that is you shouldn't have to ask for that as the person that's intubating. If you're working well together as a team, then the person that's doing the person who's not doing the laryngoscopy should know to automatically do Selleck's maneuver. So you do Selleck's maneuver, and remember that it's your job once you do it to hold it there until after we have the tube in place, the cuff is inflated, and we verified that the tube is in the appropriate place. Until such time, that Selleck's maneuver should be continuous. And remember that you'll hear people say things all the time like, I need cric pressure when they're trying to intubate, but cric pressure in and of itself doesn't significantly increase your view when you're doing laryngoscopy. In fact, there's been several studies that have shown that it may actually decrease your view somewhat. Instead, if you're having a hard time seeing when you're doing intubation, you should not be asking for cricoid pressure. You should be asking for TLM, or thyroid manipulation. By manipulating up here, if my cricoid ring is down here, by manipulating the thyroid up here, I can truly manipulate it into the place it needs to be for the laryngoscopist to be able to see his view. And probably the best way to do that is, if you're the laryngoscopist, take your assistant's hand, put it on the patient's neck, then put your hand on their hand, and then guide their thyroid to where you want it to be. And then once it's in a position where you want it to be, then tell them, okay, hold it right here, and then you can release and you can actually pass your tube. Okay, once we actually start the intubation itself, remember that when we're talking about ET tube sizes, remember in women we typically use like somewhere around a 7 to an 8. In men we usually use somewhere between an 8 and a 9. Remember in pediatrics there's several ways to calculate, but one of the ways is their age plus 16 divided by 4. And then when we talk about the blades, remember that if we're using a Miller blade or a straight blade, remember it's designed to go under the epiglottis and actually pick it up. A Mac blade is actually designed to go into the uvula, not into the uvula, into the vallecula, and actually push, if you will, and by pushing on that little tendon there, that is what actually brings the epiglottis up. When we talk about depth, remember that in women we would typically like to advance our AT tube to somewhere around 21 centimeters, and in men we'd like it to be somewhere around 23 centimeters. When you're looking at a chest x-ray, what you'd like to see is that it's at least probably somewhere between 2 and 4 centimeters above the carina. If you can't see the carina, if nothing else, what you can use as a guide is you'd like it to be somewhere around where the clavicles come together or the first ribs come together. That will help you with a placement. And in pediatric patients, remember the easiest way to figure out how deep to place the tube is 3 times the internal diameter of the tube, assuming you've used the right size tube. Now when we talk about proof, remember from ACLS you have primary and secondary proof. Primary proof basically is only one of 2 things. It's actually watching the tube go through the cords, or it's listening to lung sounds and also auscultating the absence of belly sounds. That would be our primary proof. When we talk about secondary proof is everything else. Secondary proof is things like the TUMI syringes, or using the colorimetric CO2 monitors, things like an X-ray. All that stuff is secondary proof. And the one caveat that I want to say about secondary proof is, if you have your choice, the most definitive secondary proof, in fact it's so good that a lot of people will even argue that it's primary proof, is waveform capnography. That is the gold standard. We would like to verified proof with a capnogram, with a square waveform capnogram. And that's become really more and more important from a medical legal standpoint, because one of the things that tends to that can cause legal problems is if we have a displaced ET tube. That's why a lot of services have gone to policies that have said things like, as soon as the patient's intubated, you need to prove it by printing off a waveform capnogram, and then when you turn the patient over to the hospital, before you take them off of your monitor, you need to do it again. That way you can demonstrate that the patient was intubated right afterwards and the patient was intubated when you turned them over. Okay. Now, finally, once we get the patient intubated, we need to think about post-intubation management. The big thing, obviously, is make sure that somebody's ventilating them. A lot of times we get so focused on getting the tube that once the tube is in place, everybody forgets about the patient. So you want to make sure somebody's bagging them. Remember that we want to secure the ET tube with a commercial restraint. I'm sure everybody out there knows how to use like a fishing wire and chewing gum and something else to make an ET tube restraint. But remember that this is a medical device, and if it fails, you're going to be in a lot of trouble. And so we would prefer to use something commercial. That way when it fails, the manufacturer will be in a lot of trouble. When we talk about follow-up treatment, the big thing we need to do very quickly right after we get the patient intubated is we need to give them another dose of sedatives and pain medicine. Remember that when we talk about intubation, the act of laryngoscopy and the act of pushing a tube down in the throat is extremely, extremely painful. It's one of the most painful things that we do to people. And so even if your patient's not like a quote-unquote trauma patient, every patient that you intubate, when they very first get intubated, assuming they have the hemodynamics to support it, should get pain medicine. Again, we can go back to fentanyl if we're worried about dropping blood pressure or something like that. But we would definitely want to give all those patients pain medicine if we can. The other thing, again, obviously, is they need continued sedation. And then we need to think, and here's the key, to think about paralyzing them. We have this really, really bad practice, especially in transport medicine, of paralyzing everybody just because we can. We tend to give them sedation and pain medicine, and then we tend to paralyze the crap out of them for really no good reason. When you look at the literature on paralysis, it's really pretty clear, and it's been demonstrated, and there's been a big switch in practice in the ICU. Most places now are not blindly paralyzing patients anymore in the ICU. When you paralyze patients as opposed to when you just keep them down with sedation, you increase the chance that they're going to get ventilator-acquired pneumonia, you increase the length of time that they're probably going to be on the ventilator, and you also increase the likelihood that it's going to be difficult to get them off of the ventilator. So there's a really good argument for not just arbitrarily paralyzing people anymore. We really need to critically think about whether paralysis is the right thing to do for them or not. And remember that paralysis is never indicated as a way to make patients more comfortable. Remember that there's nothing sedating about paralysis. So the one thing I would say is if you do choose to paralyze a patient, the one thing you need to make sure of before you ever even reach for the paralytic, and I'm here talking about paralysis, keeping them paralyzed, not paralyzing them to get the tube. But when we talk about continued paralysis, is you need to make sure that they're adequately pain controlled and adequately sedated first. Now, when we talk about the paralysis, there are a couple of exceptions. There are a couple times when it probably is really good to do paralysis early. And a good example of that might be traumatic brain injury. Another good example might be somebody with ARDS who you're having to use different modes of ventilation from what's normally physiologic. Another time when we might paralyze somebody pretty early is like somebody with heat stroke that we're trying to cool. So there are some times when it is appropriate to paralyze, but really the big thing with paralysis is it should be a conscious decision, not just a blind, this is what we do for everybody kind of thing. The literature has clearly demonstrated that just running around paralyzing people for no reason is not only not necessary, but it's actually potentially harmful. Now, finally, the last thing that we need to do is we need to monitor really closely. Obviously, we want to monitor like our ECG, our SaO2, our EtCO2, all that good stuff. But the other thing that we need to monitor very closely that we tend to be really bad about monitoring is actually the temperature. Remember that if you've paralyzed this patient, you've taken away their ability to warm themselves, so therefore you've bought a system you're now responsible for. And even if you haven't paralyzed them, or continue to keep them paralyzed, remember that if you've given them sucks, one of the biggest things that can kill people with sucks is malignant hypothermia. So we always want to be very cognizant about watching a temperature the first 30 minutes or 60 minutes after intubation in anybody who has been induced with medication. Okay, when we talk about the actual sedative agents, just a quick review here of some of the drugs that we can use in order to maintain sedation. One caveat here that I do want to say is when we talk about using sedative drugs as boluses or using them as drips, the one thing that we tend to do a lot of is use them as boluses because it's more convenient. But remember that when you put somebody on a sedative drip, instead of peaking and troughing, you actually maintain a plateau of sedation. So we actually can get much better sedation, much cleaner sedation, a lot of times with less drug requirement. So you've got your dosages here for drips for your most common sedative agents. So when we talk about our benzos, the two big benzos that we use as drips are Versed and lorazepam. Usually when we're using Versed as a drip, we'll use it somewhere between 0.04 and 0.2 milligrams per kilo per hour. When we use Ativan, we usually use it somewhere between 0.01 and 0.1 milligrams per hour, or excuse me, milligrams per kilo per hour. When we talk about our narcotics, two good narcotics that we can use as a drip are morphine or fentanyl. When we use morphine, we usually give it as a drip somewhere between 0.1 and 0.2 milligrams per kilo per hour. When we're giving fentanyl, we usually give it at a dose of somewhere between 1 and 3 mics per kilo per hour. We can use ketamine as a drip. When we do that, we do it at 0.5 to 4.5 micrograms per kilo per hour. When we talk about our other general anesthetic that we may use, it's propofol, which we do use a lot of propofol to maintain people, even if we don't use a lot of it for adduction. When we talk about the dosing for propofol, when we talk about normal sedation doses, a lot of textbooks will say like somewhere between 10 and 50 or 10 and 75 micrograms per kilo per hour. Once we get up to our higher doses, somewhere between 10 and 150 micrograms per kilogram per hour, then or on that higher side, like closer to 150, we're really getting into the general anesthesia portion of propofol, so we have a profound sedation there. And finally, the last one that we may use as a continuous infusion for sedation is Precedex. When we give Precedex, we usually give it at 0.2 to 0.7 micrograms per kilo per hour. And we remember that Precedex is an alpha-2 blocker. So those are some of our more common maintenance sedative drugs. Okay, when we talk about rescue airways, we already talked a little bit about rescue airways in the airway algorithms. We talked about when it was appropriate to use them. I just want to review a couple of the more common rescue airways that are out there. There's a bazillion different airway toys that are out there. We're not going to hit on every one. We're just going to hit on the big three. And we'll start with the combi tube. If you're unfamiliar with a combi tube, remember that the way that a combi tube works is it's actually two tubes that are basically just attached to each other. You have a port 1 tube and a port 2 tube. The port 1 tube actually is designed, it runs down the length of the tube, and then down at the end of the tube, which is actually going to sit in the hypopharynx, it's got holes that wrap all the way around it, so it almost looks like the old EOA or EGTA airways. When this tube is used, what's happening is we've got a bulb above it and a bulb below it that are inflated, and so by pushing air through the number 1 tube, it's being pushed through all these holes, and it has nowhere to go but into the lungs because it can't come up out of the mouth because of the cuff up here, and it can't go down to the stomach because of the cuff down below. Now, the advantage to the combi tube is it doesn't matter where it's stuck, we can use it. And what I mean by that is it's a blind insertion. We just stick it in, and if it ends up in the esophagus, which it does like 90% of the time, then we're going to use that number 1 tube, and it works great. If that doesn't work, if we put it into the trachea, then that's okay too. What we do is we put the combi tube in, we inflate both balloons, we try and bag through the number 1 port, in other words, through the one where all the holes come out the sides. And if that works, then good. If not, that tells us that the combi tube has been placed in the trachea. At that point, what we do is we just switch our BVM from the number 1 port to the number 2 port, which basically the number 2 port, all it is an ET tube. And so if we've inadvertently stuck it into the trachea, or if we purposely, for that matter, stuck it in the trachea, then we switch to the number 2 port. Again, we should hear good lung sounds, we should hear abdominal sounds, and we're good to go. The combi tube has several advantages to it. It's totally, absolutely idiot-proof in a lot of ways. The ports are labeled. You have a number 1 port and you have a number 2 port. The balloons have to be inflated in a specific order, but again, they're numbered. You have a number 1 balloon and a number 2 balloon, and it even tells you right on the pilot balloons how much air you need to put in. You put in, I believe it's like 100 cc's into one balloon, and you put, I believe it's 15 cc's into the other balloon. Now, when we talk about the combi tube, the big thing that you need to know, other things that you need to know, there's only 2 sizes. There's a small adult and an adult, and usually the cutoff is like 5 foot or so. Usually if they're less than 5 foot, a lot of times we'll put in the small adult. If they're greater than 5 foot, then we will put in the large adult. Remember that you don't want to use it in anybody who's got like esophageal bleeding. You wouldn't want to use it in anybody who's got bleeding between those 2 balloons, like any trauma patient with bleeding in the back of their throat. We would not want to use this in anybody who's ingested any kind of caustic substance, or anybody who is too short or too tall. Based on the size of tube that you have, and all that stuff is clearly delineated there on the tube, or in the instructions that come with the tube. Okay, when we talk about the King Airway, this is a newer airway. It's taken the place of the combi tube in a lot of places, not everywhere, but in a lot of places, and it has some advantages and disadvantages as well. One of the advantages of the King Airway is that it comes in a lot more sizes than the combi tube, so we can use this in a lot bigger patient population. The King Airway, the way that it's designed, you just have 1 tube, and that 1 tube has 2 balloons, just like the combi tube. You have one that's going to sit, one balloon that's going to sit in the back of the mouth, and one that's going to sit at the end of the tube. But instead of having the multiple holes radiating out in multiple ways, the way a combi tube does, the way that the King is designed is air comes down the tube right below the first balloon, or the bigger balloon. There's just one big hole that's designed to sit right about where the trachea is. And so the way that this tube is inserted, it's inserted into the esophagus, and when it's inserted into the esophagus, that one hole should sit right where the opening is that separates the esophagus from the trachea. So again, we can ventilate the trachea. Probably the biggest advantage to the King Airway, aside from the size that you have, aside from the fact that you have multiple sizes that you don't have with the combi tube, is the fact that that hole is big enough that we can actually advance a bougie down that hole. And once we've got a bougie down that hole, we could actually remove it if we needed to, and we could actually advance an ET tube. We could use it like an ET changer. So that's a big advantage with the King Airway. Now, when we talk about the LMA has by and far become like the most commonly used airway in surgery. There's a lot of advantages to the LMA, not the least of which is the fact that the training is relatively easy. There's lots of opportunities for training, and for flight programs or critical care transport programs, that is probably the biggest advantage of the LMA, is the fact that when it comes time to assure competency of your staff, there's a bazillion LMAs put in surgery every day in this country, so it's as easy as getting your staff to the OR to get them LMA experience. When we talk about the LMA, the way that it's designed, if you look at the graphic in the middle there, you see that it's designed so that it's advanced into the esophagus, and it sits right where the esophagus and trachea come together, and it's got this little inflatable balloon that looks almost like a heart, and that balloon is actually designed to push up against the trachea, and it actually creates somewhat of a seal, not really, but somewhat of a seal that allows us to push air directly up into the trachea. Now, depending on the LMA, they come in various sizes. You have them all the way from pediatric sizes to adult sizes. And depending on the LMA, it may or may not be an intubating LMA. So when you look at the LMA that's all the way off to your left, the one in the left lower corner, that's a non-intubating LMA. The only thing you could do with that LMA is place it in, and then you could ventilate through that LMA. In contrast, if you look at the one all the way to your right, that is an intubating LMA, and that intubating LMA is actually designed so that once you put it in, you can actually advance an ET tube through it and intubate with an actual ET tube. So there's several advantages to the intubating LMA. That's probably the one that most transport programs have gone with if they've gone with the LMA as their choice as a rescue airway. Okay, when we talk about surgical and needle airways, the big thing to remember is that we use these as a way to secure an airway when nothing else has worked, when the patient is rapidly deteriorating. Remember when we talked about those RSI algorithms, we said that if the patient we couldn't maintain a SAT greater than 80%, or excuse me, greater than 90%, and the patient was decompensating, we needed to go back straight to a surgical crike. But if you recall on the failed airway algorithm, the other thing that it said was that if we tried a rescue airway and that didn't work, then our other backup also was a crike. When we talk about surgical crikes versus needle crikes, it's pretty simple. The only time you do a needle crike ever is when you can't do a surgical crike for some reason. Dr. Broslow, the physician that invented the Broslow tape, I love one of his sayings. He says, if you've ever done a needle crike, you're an expert, because if you've done one, you're the only person in the room that's done one, and you'll never do one again because you know that they don't work. The big thing with needle crikes is not oxygenation so much. We can push air in under positive pressure. The big issue is that it's really hard to exhale with any effectiveness through a needle. So these patients get CO2 trappage and very quickly become hyperinflated. So when we talk about using a needle crike as a rescue airway, we're talking about using it for a very short period of time, often no more than like 5 minutes or so. In contrast with the surgical crike, we can make a much bigger opening so that we can put in an adequately sized tube that allows for adequate minute volume. So we can not only manage the patient's oxygenation, we can also manage their ventilation. When we talk about the contraindications, the big thing you need to know is there's really only one absolute contraindication, and that's inability to locate the landmarks. Now, if we follow that through, American College of Surgeons, they're the ones that kind of write the Bible on crikes because it's a surgical procedure. They say typically that we don't do crikes in kids who are less than like 8 or 10 years old, but again, it's because of a relative inability to locate the landmark. So, how do we actually do a crike itself? Well, when we do a crike, the very first thing that we have to do is identify the membrane. So the first thing you're going to do is you're going to find the thyroid. And if you'll recall working down your anatomy, you've got this nice big thyroid. You've got this little bump right here. And then right on the other side of the bump, you have a very rigid ring, which is your cricoid ring. Well, between the thyroid and the cricoid ring, that little bump that you felt, that little depression that you felt, that is the cricothyroid membrane. That is what we are shooting for when we do a crike. That is where we want to place our airway at. So when we do a crike, what you're going to do is you're going to take your weak hand, whichever hand is your weak hand, and you're actually going to put that on the patient's thyroid. When you put that on the patient's thyroid, probably one of the easier places to sit is off to their side or sit at their head. And once you've put your hand on their thyroid, that hand is now stuck there. It doesn't leave there. So once you've got that hand stabilizing the thyroid, then you're going to take a scalpel, preferably a number 11 if you got it, and you're going to make an incision straight down. Now, there are a lot of things that people can do to screw up a crike, but one of the very first things they can do to screw up a crike is in the initial incision. One of the worst things you can do in that initial incision is not make it big enough. You need to make that incision big enough. You need to make it large enough that you can actually work inside the incision. So it's not uncommon to have to make an incision that's like probably 2 centimeters long. So you're talking about a pretty good sized incision. And for all of us English people out there that are used to the American system, you're talking about a good 1.5 inches or so. So we're talking about a fairly decent incision that we want there. We want enough room to work in it. Now you're going to make that incision just deep enough to cut through the skin and the subcutaneous tissue. Once you've cut through the subcutaneous tissue, the thing that you need to be cognizant of is if you've never done a crike or seen a crike before, and if the patient has a pulse, it is going to bleed like crazy. That can't freak you out. You've got to keep going. Just take a deep breath, don't panic, and realize that that's normal. Part of the reason why that's normal is running along the top of the cricothyroid membrane is the actual thyroid artery, and so when you cut through that, it's not uncommon to cut through that. and for the patient to start arterial bleeding. So you may have a fair amount of bleeding right there. Now, knowing that, that's why it's so important you know your anatomy, because this is not a technique that we do based on vision. This is a technique we do on feel, because you're not going to be able to visualize because the field is going to be full of blood. So remember we said this hand was stuck right here? Well, while this hand is stuck here holding the thyroid, after we've made our initial incision, then what we're going to do is we're going to take this finger right here and we're going to stick it in the hole, and we're going to verify that we're still where we want to be, that we're still sitting just below the thyroid and just above the cricoid ring. Once we're sure that that's where we're at, then we're going to take our scalpel and we're going to actually rotate it 90 degrees. So now the blade is going to be across the patient's body instead of along the patient's body. And then we're just going to poke straight in. And when we poke straight in, we want to make a big enough hole that we can get our pinky inside of it. So we poke straight in, and remember the rule in surgery is that we never, ever, ever take anything out of a body cavity till we put something else in. So when you push your scalpel in, you want to push your scalpel in and then hold it there for a second. Don't just poke it and pull it back out. So we poke in, we hold it, and then what we're going to do is we're going to take a tracheal hook or a bougie or a stylet that we've bent the corner on, some kind of device to maintain traction on the trachea, and we're going to stick it in. If we're doing this right, if we're using the appropriate equipment, the right tool for this is a tracheal hook. So we would take a tracheal hook, we would stick it in, and we would pull up, or we could even take the tracheal hook and put it on the other side and pull up this way. And then what we're going to do is, now that we can see down into the trachea, we're going to pull out our scalpel and toss our scalpel to the side. Now that that hole is being maintained by our tracheal hook or our bougie or whatever, then what we're going to do is we're going to take our tube and advance it into place. Now, in these graphics here, one of the things that you see in the lower graphic is you actually see these things that look like alligator clips or that look like pliers. Those that tool is actually a tool that we could use to dilate that area. It's called a trousseau dilator. Some places use those to maintain that hole. Some places use tracheal hooks. And again, some places have even used things like bougies. The big thing with the trousseau dilator, if you've never used one before, the one thing you want to be cognizant of is they're very slick. And this is a very bloody procedure, so it's not uncommon for you to stick in the trousseau dilator, open it, and it pops out. So you want to be very careful if you're using a trousseau dilator that it doesn't pop out and you lose your space. Now, I said there were several things that you could do to screw up a crike. I said the first thing that you could do to screw up a crike was the fact that you could make your incision too small. The second thing that you can do to screw up a crike is failing to make absolutely positively sure that you're in the trachea. If you've never done a crike before, just know that if you take the ET tube and you advance it in the subcutaneous tissue right next to the trachea, it will slide down that slick as snot on a doorknob. It works really, really easy. And you'll think you're inside the trachea because you meet relatively no resistance. But you're not in the trachea. So we want to make absolutely sure we're in the trachea. Well, how do we do that? Well, there's a couple ways we do that. The first thing I always recommend when I'm teaching our students how to crike is I always recommend that you make freaking sure somebody continues to bag. Because if they're still bagging the patient, when you pop through that cricothyroid membrane, assuming there's not an obstruction above it, as soon as you pop through and they ventilate, you're going to spray blood everywhere. But the advantage to that is a visual and a tactile reference to verify for you that you've actually made it into the trachea. The second big thing that I always tell people is that you don't take any instrument out until you put another one in, which we already talked about. And finally, you need to confirm your crike just like you would confirm any other airway. Get EtCO2 on right off the bat. You're looking for a square waveform. Make sure that you've got good lung sounds. Make sure there's no belly sounds. And once you've got all that secured, then you want to bandage it, apply pressure there as much as you can to stop what local bleeding is there. And then obviously we want to get that ET tube secured. All right. Well, I think that is all I've got today for Airway. Thank you very much for being with us. I really appreciate you. If you have any questions, feel free to email me. My name is Anthony Baca again, and my email address is abaca, that's A-B-A-C-A, at camanagement.org. That's CA as in clinical analysis, management.org. Or you can visit us on our website, which is www.camanagement.org, www.camanagement.org. Thank you so much for all that you do. I hope that you have a great day, and thanks again for being with us.
I'd come for you, no one.